Thank you, Dr. Vaishali. It's a pleasure being here and going to speak on a subject. So I'm not going to begin with a very evidence-based slide, so I hope you'll indulge me. This is a painting by a Spanish artist called Velázquez. And if you look at the painting, let me try to put the laser pointer. So if you look at this painting, this is supposed to be about the princess, but the painting is called Las Meninas, and it is actually means ladies in waiting. So while it's about the princess, the painting has focused on all the ladies in waiting, the courtiers and the people who accompany the princess. And in fact, if you see the artist, he's drawn himself, and he's looking a little irritated, probably because the king and the queen are actually featured in the mirror and they are actually watching him from outside, and he's got interrupted. You'll also see that the focus of the painting actually is this lady. Her name is Maria or Mary Barbola, and there's also a little boy there who's trying to taunt the dog, and she's short and is obese, but I'll talk more about this painting in the end. So this is a 15-year-old adolescent girl. Another case, very simple case, nothing very complicated. Has type 2 diabetes for 2 years, hypertension, irregular periods, excess hair growth, fatty liver, no Cushingoid or hypothyroid features. The growth chart shows obesity. As you can see, the body mass index of this girl is actually well above all the centiles. And just to refresh your memory, if the body mass index is more than 95th centile, BMI is 95th centile for age, we call it obesity. 85th to 95th centile, we call it overweight. More than the 99th centile, we call it severe obesity. Adolescent obesity is defined by BMI more than 30, and more than 85th centile you have to evaluate if there are complications. If you go back to this lady, her fasting and postprandial are both high, the HbA1c is high, the LDL is high, the AST-ALT are high, there is fatty liver, the thyroid and the cortisol workup are all normal. So she has obesity, atherogenic dyslipidemia, uncontrolled diabetes mellitus, hypertension, polycystic ovarian syndrome, and non-alcoholic steatohepatitis. So this is a classic, you can call it idiopathic or constitutional obesity, and this is a secondary cause of obesity. A young 6-year-old boy with obesity, looks Cushingoid, has sexual precocity, clearly hypercortisolemia, and also has high androgen levels, and as an adrenal carcinoma. So if you find a child who's short or has other endocrine abnormalities with obesity, look for a secondary cause. This is again a case of obesity, but you can see the polydactyly and other features suggesting Bardet-Biedl syndrome. If you look at the hypothalamus, as you know, has an arcuate nucleus at its very center, and you have the paraventricular nucleus elsewhere. Leptin, with increasing obesity, leptin binds to its receptor. It stimulates the pro-opiomelanocortin, and that stimulates the melanocortin 4 receptor pathway and helps to control the weight. But if there is a blockage anywhere in either the POMC neuron system or the melanocortin 4 neuron systems, you're going to get obesity, because that's going to increase the appetite, decrease the energy expenditure, and increase the body weight. So the hypothalamus is very critical in weight maintenance, and especially the leptin melanocortin 4 pathway tells the body not hungry, not hungry, not hungry, and if that is blocked, you get the hunger signals. So if you look at the melanocortin 4 pathway, and this is blocked in many conditions including hypothalamic tumors and Bardet-Biedl syndrome, and you can think of these signals going through the pathway as trucks which are carrying the signal not hungry, not hungry, not hungry, and you can see the green signal allowing the not hungry signals to pass, telling the brain to suppress appetite. But what if this signaling system itself is blocked? If the signaling system itself is blocked, the not hungry signals don't reach the brain. And when those don't reach the brain, what happens is hunger happens and people put on weight. That's one of the reasons why in many conditions of hypothalamic obesity, genetic conditions and other conditions, you get obesity because the signal has been blocked. But imagine if at this point you get a innovative, slides aren't moving. Yes, if you get a traffic policeman who decides, ignore that signal, I'm going to change the red signal to a brand new green signal, and I'm going to restore the melanocortin 4 pathway, and that means the not hungry signals reach the brain, and the brain knows you're no longer hungry, and the appetite is shut down, energy expenditure increases, obesity is corrected. So recently, set melanotide, which actually does that, it restores the melanocortin pathway, because we know that when leptin binds to the leptin receptor on the arcuate nucleus, that stimulates the melanocortin 4 pathway, because melanocortin MSH binds to the melanocortin 4 receptors, and that triggers suppression of appetite, decrease in weight, and increase in energy expenditure. Set melanotide restores that pathway, and it is being explored in several conditions, including pro-pure melanocortin deficiency obesity, where you might, because of the absence of alpha MSH, you might get red hair and lack of pigmentation. Leptin receptor deficiency, Bardet-Biedl syndrome and Alstom syndrome, and several other syndromes, and it has received, the US FDA has actually approved set melanotide recently for chronic weight management in adult and pediatric patients who are more than 6 years old and obesity, and it is the first drug to receive approval for chronic weight management, because 7.9% of the body mass index can actually come down. The problem with the drug is it can increase suicidal ideation, because set melanotide has some effect on sexual arousals also, so it can also improve sexual arousal. Some analogs of the drug are actually used in hypoactive sexual disorder syndromes. It can also increase pigmentation. So many of these youngsters may have acanthosis nigricans. It's not going to improve. In fact, it's going to become worse, because it will cross-react with melanocortin receptors on the skin and cause pigmentation by melanin production. Phytomelanin will be produced instead of eumelanin. So this is the approval status as of November 2020 and beyond, and the indications are increasing. Coming back to the first case, if you see, that's a 15-year-old adolescent. She has diabetes for 2 years with hypertension, polycystic ovarian disease, NAFLD. What is the best therapy for her weight loss? You could look at diet, you could look at exercise, you could look at medical therapy, you could look at surgery. I'm not sure if patients will agree for bariatric surgery. I hope I'm not exceeding my time, because the timer is stopped at 14:37. But yeah, do ring the bell. Yes. But I usually finish minutes earlier, so don't have to. I hope you don't have to ring the bell. But if you look at semaglutide is an option for such children in future. So there is a study called a STEP-TEEN study, but before that, I just want to highlight semaglutide, which is a human GLP-1 analog. Where does it act? It acts on the hypothalamus. It stimulates the leptin receptor pathway. It also acts on the hindbrain and the brainstem, and it stimulates the vagal pathway, the nucleus of the tractus solitarius, which also affects the sympathetic drive. So this reduces cravings, it reduces energy intake, it also has other metabolic and cardiovascular effects. So semaglutide was studied, and this paper came very recently, called a STEP-TEEN study. In this study, they took teenagers between 12 to 18 years. They took teenagers with a BMI more than the 95th centile or more than 85th centile with more than one weight-related comorbidity, with more than one unsuccessful dietary weight loss attempts, The key exclusion criteria was a major depressive disorder within 2 years of screening or severe psychiatric disorders. The study aimed to see the efficacy and safety of 2.4 milligrams of semaglutide weekly in teenagers aged between 12 to 18 years with overweight or obesity. This was a randomized, double-blind, multinational study at 37 sites between October 2019 and March 2022. They started with 0.25 mg of semaglutide a week and escalated the dose to 2.4 mg over 16 weeks. The outcomes were percentage change in BMI, the achievement of more than 5% weight loss, and of course the safety endpoints. So this was the schedule followed for semaglutide. So of course lifestyle intervention is the basis of all obesity therapies, and that includes behavior counseling, stress reduction, low calorie, low carb diets, exercise. So that's the basis of all treatments. The randomization followed a 2:1 schedule. One group was given placebo and the other group was given semaglutide, and the dose was 0.25 mg, stepped up every 2 weeks to 0.5 mg, then 1 mg, then 1.7 mg, then up to 2.4 mg. And this study was done for 68 weeks, and then there was a post-study 7-week follow-up. So there was the run-in period, the dose escalation period, the maintenance period, and the follow-up period. What the study results showed that in teenagers with the mean baseline BMI of 37 kilograms per meter square, there was a BMI reduction of 17.9% with semaglutide compared to placebo. So very strong reduction, and also you can see the categorical body weight loss. More patients lost weight on semaglutide compared to placebo. If you look at, say, more than 20% weight loss, 40% of these teenagers lost more than 20% of their body weight. So semaglutide 2.4 mg was superior to placebo with respect to BMI change. So that was the primary endpoint. And if you see just the weight, the reduction in body weight, 17 kilos of weight was reduced in semaglutide, which is quite remarkable, as we know that childhood obesity or adolescent obesity, it is a lifestyle disorder. Lifestyle is the key, but lifestyle isn't that easy, and bariatric surgery also isn't that easy either. So this semaglutide is expected to occupy that space between lifestyle modifications and bariatric surgery and fill in that gap. And of course, setmelanotide is going to be used for the other hypothalamic genetic disorders, as I talked about earlier. So this is, you can see, about 17 kg weight loss, which is pretty dramatic, and in the placebo group also there was 2.3 kilograms weight loss. So in this study, semaglutide was superior to placebo. Improvement was seen in all other weight-related parameters, including glucose metabolism and cardiovascular risk factors. Safety and tolerability was consistent across the STEP trials, and it was 2.4 mg. The benefit risk profile appears to be favorable in adolescents, so that's going to come up. So some of my take-home messages are that if you see a young child or an adolescent, and if there is a good height, and along with that if there's obesity, that's likely to be constitutional or idiopathic obesity. But if there is short stature or some syndromic features, I showed you a case of adrenal carcinoma co-producing adrenal steroids as well as androgens as well as cortisol. So if we find features like that, then look for a secondary cause of obesity. If there is subnormal height, you need to work up for secondary causes of obesity. It's important to not just look at obesity but also treat the comorbidities of obesity. Diet and exercise are the mainstay. In future, you're going to have so many treatments of obesity, and hypothalamus and leptin are of immediate research, and I talked about setmelanotide as well. So I showed you this painting in the beginning, but before going back to this painting of Las Meninas, I'd like to say that people look at obesity as diet and exercise problem, as calorie in, calorie out problem. That's not why obesity occurs. That's how obesity occurs. Obesity is a complex interplay of biology, society, community, family, and of course, the availability of facilities to exercise, the availability of junk food, and so many factors. It's not just a single player there. Imagine that if you have come back from home, and I don't know again if I have time left. So if you come back home, if somebody's come back home and you find donuts on the table, you've come back home stressed from work, and then the sweet aroma of the sugar on the donuts is actually wafting into your nose. So there are several problems there. The easy availability of junk food, which is not being taxed, the family atmosphere where this junk food is available, the lack of avenues to tackle the stress, and so many other things. And before the person, anybody knows it, you've not just eaten that donut, you've eaten a whole packet of donuts, and you're left with an empty box of donuts and a mind full of guilt. So obesity isn't just about a diet and exercise, or for that matter, set melanotide or semaglutide. So coming back to this painting, you can see Velázquez looking scornfully at the king and the queen who've interrupted his painting. You can look at the princess who's dressed very well but isn't actually stealing the thunder. On the other hand, if you see Maria Barbola is actually the most well represented or well presented person in this painting. She's short, has stubby fingers, has a normal sized torso, but limbs appear to be short. There is a frontal bossing, but if you see the chin, there's no mid-facial or chin hypoplasia. So probably she has achondroplasia, and achondroplasics are actually known to have chronic diseases like type 2 diabetes, obesity, and so on. And then if you look at the other dwarf, those days the courtiers had dwarfs in the court. The other dwarf was called Nicolas Pertusato, and he's also a dwarf, and he's playfully trying to kick the dog. We don't know what happened after that. But if you look at this dwarf seems to have, this boy rather seems to have frontal bossing and some degree of chin hypoplasia. If you look at journals, they've said that he has hypothyroidism. I disagree. Seems to have, maybe if there's hypothyroidism, it could be a central hypothyroidism. Seems to have combined growth hormone deficiency and hypothyroidism. And another message is that hypothyroidism isn't associated with weight gain. So that's another message there. And this, while growth hormone deficiency can be associated with some weight gain and some muscle loss as well. The point I'm trying to make is that Velázquez, even those days, in fact the name Mary Barbola came from the word barbarian comes from the word Barbola, shows that these people with such disabilities in those days were looked upon as barbarians. And certainly our painter Velázquez didn't think so. In fact, he painted both of them as the most well-dressed and elegant among the two, showing you that these thoughts of not shaming people with short stature or obesity were there even in those years as well. And it's not that they don't live a healthy life. In fact, if you see the positive part is that Mary Barbola actually is supposed to have lived to the age of 70 or beyond. So lots of messages from this painting. Again, this was not an evidence-based slide, and thank you for indulging me. It's been a pleasure talking to you. Thank you for listening to me.